30 to 40 million men have erectile dysfunction in the U.S., and we classify it as either mild, moderate, or severe. Next slide. So, in 2015, what we have for the treatment of ED, and from now on we'll call erectile dysfunction ED, we have testosterone therapy, and it can be in any form, either pellets, gels, injection, or they even have a nasal spray now. Oral medication, ever since March 28, 1998, Viagra became FDA approved, the fastest drug ever to win FDA approval. And then Cialis, Levitra, and Stendra. These are all classification of medications called PDE5 inhibitors. Vacuum therapy has really been around since the early 80s. You create negative pressure on the penis. It fills with blood. You put a ring around the base of the penis and you have an erection. Penile injection therapy, there's basically two types. There's what we call Trimix, which is not an FDA-approved medication, and I no longer prescribe it because it's not FDA approved. And then there's prostaglandin E1 or Edex, which is an FDA-approved medication. It's the same thing as prostaglandin E1 in the form of Caberjet or Edex. And then we have penile implant surgery, which has been around since the mid-60s and evolving over the course of many years till we have really a very reliable implant now. And then now we have platelet-rich plasma, or PRP. This was first developed in 2010. Next slide. By Dr. Charles Reynolds, an internist. Platelet-rich plasma has three compositions of plasma: the white cells, platelets, and red blood cells. So plasma and platelets contain growth factors for regeneration and rejuvenation of tissues. Next slide. So PRP has been around for 20 years. Notably in orthopedic surgery. A cardiac surgeon was the first one to utilize it in 1987. And what they did was they used PRP to close the wounds. After the sutures were placed on the wounds on thoracic surgery, PRP was applied. They cut down the infection rate by 50%. Kobe Bryant, basketball player, shoulder injury, PRP helped return him back to the basketball court. Tiger Woods had a knee injury. He had PRP applied to his knee. So it's been used in the pain industry, osteoarthritis, dermatology. It's been used for the vampire facelift, for hair loss, in dentistry. And then, as I mentioned, Charles Reynolds in 2010, he developed the P shot, Priapus shot, and the O shot, O for orgasm. Next slide. So, how does it work? You take the patient's blood, about 60 cc's. You spin it down in a centrifuge at about 11,000 RPMs for anywhere from 6 to 9 minutes. The platelet-rich plasma, then we add calcium chloride as a growth factor that stimulates growth factors, and we inject it into the penis. Next slide. So, as I mentioned, on Charles Reynolds in 2010, an internist, and my mentor, Elizabeth Roy. Well, this whole idea about PRP, you've seen it on the internet. It's been in Cosmo magazine. It's been on the doctors. The problem with PRP is that it's only been used by internists, family practitioners, people who are in anti-aging medicine. So Dr. Roy was introduced to me at the Sexual Medicine Society, and what she quickly realized, and I realized that, excuse me, this is a great system. There's no data in our literature that talks about this. So Dr. Roy came to town, and she spent 3 days with me, and she taught me the technique on the first 10 patients. And as soon as I finished, we went out to dinner that night. And I said, you know, in order to make this really successful, we need to have clinical data. Because, excuse me, just hearing from patients is really not enough in a specialty literature. It's good that, you know, and I'll tell you about how patients feel, and I have a patient up here who will tell you his walk through the park, as you might say. But so we're in the process of, Dr. Reynolds is even channeling funds for this project, and we've applied for a grant. And we hope to do a prospective randomized double-blind study within the next several months. And hopefully I'm going to present that data at the Sexual Medicine Society in 2016. In October of next month, I'm presenting at the annual Congress of Sexual Medicine, and I'm talking about PRP, giving the audience an introduction. Next slide. So PRP for ED, known as the P shot. Okay, so it's a specific method of isolating different growth factors and attracting the stem cells. You know, you can think of PRP as the architecture, the scaffolding of repairing tissue, and it attracts the stem cells, and the stem cells are what proliferate and differentiate into normal tissue. PRP attracts the body's own stem cells into the area. You know, I think if we could fast forward to 2017, I think we will be doing PRP with concentrated stem cells. Dr. Kira from Baylor University is set to do a stem cell project, which I hope to be part of. He and Dr. Goldstein from San Diego. They're looking at coming up with a method of concentrated stem cells and doing this for erectile dysfunction. So right now, if we wanted to get a heavy concentration of stem cells, I would go into your bone marrow and get them out. What we're going to do is try to get stem cells from a company that are undifferentiated, and I don't know where the source of the stem cells is yet, but it's undifferentiated. It's not from your body, but it will be injected in at high concentrations to give more of an effect. So I think PRP is always going to be here. Whether or not we add stem cells from the patient, you can also get them from adipose tissue also with ultrasound in the abdomen. So that's where it stands right now. But PRP does utilize stem cells. I think what's going to come out in the next several years is adding stem cells to the PRP. So 52% of men, between 40 and 70 have either mild, moderate erectile dysfunction. PRP is the only ED therapy that increases blood flow to the penis. The Priapus shot is a specific method for isolating growth factors and attracting the stem cells to regenerate and rejuvenate tissue. In our own literature, in the Journal of Sexual Medicine, there's only been one article in 2012 that we took a rat model and there was a nerve injury, and we showed that the nerve was regenerated and rejuvenated by using PRP. It's been the only study. Next slide. So we had 4 different types of anesthetic into a cream, and we apply that to the entire shaft of the penis. Then we draw the blood. Then we spin it down, and that's a 15 to 20 minute process. And then after 10 minutes, a ring is placed on at the base of the penis, trapping the blood. And then, depending on the patient's problem, we inject at various sites along the penis. Next slide. So the results immediately larger in length and girth. There's if patient has a curvature of the penis, we see a straightening over a period of time. And I've been using this for patients who have Peyronie's disease or curvature of the penis from a penile fracture, and it has shown great results. Increase in sensation and pleasure. Almost every patient has noticed there's an increase in sensation, increase in stamina. There's no allergic reaction because you're using your own blood. Increase of circulation within the penis for a healthier penis. And it helps make other therapies. So a perfect patient would be patients who were fine with Viagra, Cialis, Levitra, Stendra. Now it no longer works. Now you use PRP, and many times those therapies are useful again. Next. So, does it hurt? Well, it's no more than a needle stick to draw blood. How long does the procedure last? Excellent question, asked all the time. You notice the full effect in 3 months, 12 weeks. There are some people that, may want a second shot, and usually we'll give that somewhere between 6 and 12 weeks, depending on what their results are. There's no anesthesia, just the local anesthesia, which, believe me, is enough. So there's no hospital stay. It says it takes about an hour from the time you come into the office to the time you leave. It's about an hour. A total office procedure. Next slide. So, are there side effects? Well, on there's no known side effects because we're reintroducing your own blood. I think there's always a chance for infection. Dr. Roy and Dr. Reynolds, who have done literally thousands of PRP procedures for the whole body, have never noticed an infection. But an infection is possible. I've never seen one in the 70 or so that I've done. Insurance does not cover this procedure at this time, and it may be several months before it does, or even years. So, is it permanent? It's permanent. However, as I mentioned, some people require a second or third shot, especially in conditions like Peyronie's disease, when you have a curvature and you have some mild erectile function. Many times, 3 shots are utilized for that to straighten out the penis. Next slide. Okay, before we go into that, are there any questions about the P shot that I can answer?
Neither. It's because the nerves in the penis are rejuvenated and regenerated, so they're more prone to sensitivity. And I think Pat's going to mention that aspect. So it's nerve regeneration. So one of the main reasons why I've been thinking about PRP and stem cell therapy for so long is because I really get frustrated with patients going to one office. We don't have any in Central Illinois, but in Chicago, Atlanta, Boston, we have these shot clinics where people go in and they'll spend $2,000 or $3,000, $4,000 for these injection therapy, and all they're doing is really giving them trimix therapy. Then you can say, well, and then you have family practitioners who I think do a great job. He or she, sees people. They give them Viagra, Cialis, Levitra. It works. And 35%, it doesn't work. Well, I'm sorry, that's all. I can't tell you how many men have come to my practice and weren't offered anything else. It happens in internist's office, it happens in family practitioner's office, it happens in urologist's office. So, not all people are going to be helped by vacuum therapy. And surprisingly, not all people are going to be helped by PRP. So, if you're at the severe end of the spectrum for ED, then the only thing that's probably going to work is a penile implant. And so, once a month, I have the same group of people, different group of people who are here specifically wanting questions and answers about penile implant surgery. So what I'm trying to say is that when you come to Midwest Urology, you're going to get the full range of treatments that are available. So, that's why someone can come into the office and I can say, hey, by the end of 3 months, I can cure you. I don't know how I'm going to do that, but we're going to take steps. We're going to get a history, obtain a history. We're going to perform a physical examination. We're going to obtain blood tests. We're going to perform a penile duplex ultrasound. We're going to take all that data and then decide what's best for you and go from there. And yes, there are some people that PRP will not help. There are some, and we don't know, unless the patient is really far gone, PRP is a good alternative. There's no question. I've had some people that say, well, you know what? My insurance covers the penile implant, but PRP isn't covered. I'm just going to go to the penile implant. Well, that's fine. That's your prerogative to do that. But I want to be able to have all forms of therapy under one roof. This is an important concept which we're going to talk about. So the patient is there, lying on the table. He just had his P shot. The ring is at the base. I wait another 10 minutes. Everyone is given, if there's no contraindication, a box of daily Cialis, 5 milligram tablets. They're also provided with a vacuum pump. And I teach each person how to use the vacuum pump in the proper way. And so what's happening is that we're taking Cialis and the vacuum pump and cycling, because what you said really is the more times we cycle the penis,
the more growth we're going to have, the more regeneration and rejuvenation is going to occur. So it's just not the shot, and I'm sorry I didn't say this ahead of time, but we do have a whole program, and we have the patient perform 6 cycles twice a day, every day for 12 weeks. So this is beneficial. When we do the clinical trial, we will have 2 groups of patients, and only I will know the patients that get the PRP, and the other patients will get saline. And so then everything else will be the same. And so there's really strict criteria that we use. Like every patient that is a candidate for PRP, we measure their sensitivity. So before, and again at 4 weeks, and again at 12 weeks. And it'll probably be 4, 8, and 12 weeks. So we should see an increase in sensitivity, by what the patients are telling me. Yep. I've probably performed at 70 patients. So, what you're asking, is that refractory period shortened, and can you go again a second time in a night? I could say the only way that's going to occur is possibly with PRP, but definitely with a penile implant. Any other questions on the P shot? Okay, next slide. So, I'm going to provide you with books and a copy of the Cosmopolitan article about the O shot. So 30 to 50% of women suffer from sexual problems, sexual arousal, low desire, hypoactive sexual disorder, pain with intercourse. So when the women come in, much the same: history, physical exam, finding out what medications they take, labs are taken, make sure that their estrogen levels are good, their testosterone levels are good. Next slide. So, urinary incontinence. This is what I don't like about calling it the O shot or the article that was in Cosmopolitan, because all they did was focus on sex. But this is really twofold. It takes care of incontinence in some patients who have stress incontinence, when you cough, laugh, or sneeze. And if it's mild to moderate, the O shot can be very helpful. Overactive bladder, urgency with or without incontinence. I can say this because my wife said I could, that she did have the O shot, and she was getting up 4 and 5 times a night. And she had the O shot, and she sleeps throughout the night now. Next slide. So what can you expect? Increased arousal, desire, more frequent orgasm, stronger orgasm, decreased pain, more lubrication, less vaginal dryness. Certain conditions like sclerosis are cured with PRP, and a decrease in urinary incontinence. Next slide. So, again, as I started off, it's been on Fox, it's been in Redbook and Cosmopolitan, The View, The Doctors. Interestingly enough, they give certificates for the O shot were given out to the actresses at the Oscars. So that's the book that I'm going to present.
The O shot, and I'm going to explain that also. So let's just think of the urethra inside the vagina. On either side, the periurethral glands. Distal in, 1 centimeter in, PRP is injected. And then PRP is injected in the clitoris. The patient is given the same numbing medicine that the man has, plus an extra shot of xylocaine right on the side of the clitoris to further lessen the discomfort. Probably about, of the 70, probably 20 have been women, and every one of them have tolerated it very well. Is there some discomfort for the men and the women? Yes, there's some, but it's certainly not unbearable where I think, geez, we've got to put some of these people to sleep. The numbing medicine, the local anesthetic that we use is really great numbing agent. Questions? Been thinking about that for the last several days, wanting to know, wanting to think if how I could get to the external sphincter and use it as a bulking agent and a rejuvenation agent where the nerves are without the use of a cystoscope. And I'm going to talk to my colleagues next month at our annual meeting. Now I'd like to have Pat come up here and tell his experience.
Well, I had prostate cancer about 6 years ago, and because of that, I had my prostate out in surgery. Went and had specialists do it. It's supposed to be nerve sparing, so I shouldn't have any problems afterwards. And as luck would have it, I was one of the 5% that had just total loss. I mean, I had no function at all. And he showed one of the slides of what some of the treatments are for ED. I literally had done all of them, and none of them worked. I even had the implant put in, and had complications with that, had taken out. So when he told me about PRP, I'm like, oh, I got to lose. So tried that, and it has made a huge difference, absolutely huge difference. I told my wife I renamed myself Lazarus because it's back from the dead. But now I still have to use the vacuum pump, and I still have to wear a ring. But before that did me no good. I could use the vacuum pump and wear a ring and still wasn't any good. So it's made a big difference for me. And the procedure itself really does not hurt. I don't have the best tolerance for pain. Like when they did the biopsy, he was telling me that it wasn't Dr. Mano, but when they did my biopsy, he's like, "No, we'll do it in the office." I'm like, "You're knocking me out. You're not doing that." And so when I have this done, it's, I did injection therapy too, so I did that to myself. It's certainly not, it wasn't come off the table bad, that's for sure. Right? A couple times I felt it, but it wasn't even bad. No side effects at all, none whatsoever. Sensitivity for me is the thing that is really, really the best. Even after the shot, I was still, even after surgery, I was still able to have an orgasm, but it takes a long time. A long time. To where my wife's like, "What? Okay, done yet or what?" So that's made a big difference. And I have literally increased my length 1.25 inches, and my girth by probably an inch. Yeah. he had asked me, about the sensitivity and stuff. I said, well, when the nurse was getting me ready, and just her cleaning the area, I felt like, it was almost like I was getting ready to have sex. I could feel it that much. Just her touching me, it was like, wow. It was 5 years since I felt like that. That's for sure.
So how much longer do you use the pump in your brain? Forever, or is there a date for that?
I don't really know. I don't think there's any expectation on my part, at least, that that I won't have to use it the rest of my life. But if I don't, then that's that much better. But I was literally dead overweight. It was that bad. There's nothing wrong. So I appreciate it. Yep.
Thank you.
Thanks, Bob.
So one thing that I want to say is that this is a patient, not a normal patient, somebody who had a complication, and thank God, I don't have very many complications. But from time to time, over the course of 30 plus years of performing penile implants, now I place more than ever before. I probably hit 150 this year. Sometimes people do have decreased sensation at the glands. Doesn't happen very much because we have a minimal invasive technique. However, when that does happen, I know these patients and I feel for them. You know what I say? If they have a penile implant, I'm going to inject them at the gland's penis, the head of the penis, very carefully so I don't injure the implant. And I've done it to 3 patients now. They've all noticed an improvement. All noticed an improvement with their sensitivity. They love the penile implant. The only thing is they weren't having the greatest sensation, and this is helping. From when Charles Reynolds first performed Pisha, we're doing it slightly different now. I think we're learning more. He's come to me and talked about how we keep the ring on for longer and trap the blood in there for a period of time. We're using more numbing meds.
And I think this is an evolving process. I don't think this will look any way like it is 3 years from now. It'll be different. And it's going to take ED specialists to pave the way. Because I can tell you that I had 3 patients in a row on Monday who were follow-ups from August 21st. First person said, my orgasm was cosmic. What do you mean by cosmic? He says, it was out of this world. It was so intense. Next person, my girth was better, my length was longer. It was great. The third person said, I only had about a 10% improvement. And I said, really? So I started asking him questions. I said, what about the length and the girth and your erections? Oh yeah, all that was much better. It was my curvature that only went from 20 degrees curvature down to 10. It's still curved. I said, okay. Those were 3 people right in a row. Now, has every single patient been helped with PRP? No. Has every single patient been helped with a penile implant? No. Nothing is 100%. We try to make it that way. And I think that the more we try, the more we're going to achieve our goal. If someone asked me a question, and they did at the last visit, what do I think is more successful, the P shot or the O shot? I'd have to really say the O shot is more successful. I mean, that only almost achieves 90% success. I mean, I haven't, to this date, had a woman come back to me and said she wasn't helped in some way. Okay, I haven't had very many men say they weren't helped in some way, but some were wanting a little more than what had. And depending on the particular circumstances, they may need a second shot, or they may need to be thinking about something else. Any other questions? No, age is not a factor. I've men as young as 38, women as young as mid-20s. On the other side, men as old as 82, women as old as scheduled 89, but already done. And I'm doing her strictly for urinary incontinence. Nothing has helped her. And so I had a nice talk with her and her daughter, and she's on the schedule for next week or the week after.
Pat had mentioned
You can stop it after the 12 weeks. We think that increase of blood flow to the penis on a very regular basis helps regenerate and rejuvenate that tissue. So, I had one person come to me and says, you know what, I just want the shot done, I don't want to do anything else. And I said, I'm not going to do it because you're wasting your money. I mean, this is part of the deal. I think too many times, maybe we'll say a long time ago, people just, wanted a shot. People have to take control. I talked to a group of endocrinologists about testosterone therapy in Springfield at lunch. And I said, we practice reactive medicine right now. But when I teach the medical students and the residents, it's all about prevention. I said, in Canada, every pack of cigarettes has a cigarette with the ash bent like that. And it says, smoking causes impotence. It's really not even mentioned that much in the United States. It talks about lung cancer. But as a urologist, I know it causes a hell of a lot of bladder cancer. And it causes a lot of erectile dysfunction. So, and there's been elegant studies to show that there's a chronic effect of obstruction in the inside of the arteries and an acute spasming of the arteries with cigarette smoking. So, I was telling them, my greatest goal is to take a patient who's on a variety of medications, get him into an exercise program, get him to lose weight, lose his medications, get his testosterone straightened out, and not need anything for erections. That only happens a couple times a year to me. But when it does, I'm a happy camper. But those are few and far between. But I think more and more, the insurance companies, the government, we're all going to have a say in our well-being. And so for the person who smokes, we try to get them to quit smoking. It's an addiction. For the person, when I tell them it's a combination of nutrition and exercise, it really is. But it's 80% nutrition, 20% exercise. And invariably, some people say, geez, my knee died. It's a football injury from a long time ago. I said, is your mouth injured? And they look at me and, they get it. Because it is mostly about nutrition. And you can reverse it. I had, just as I was driving here, one of my friends called me up to tell me that his wife, who had terrible cholesterol, all the members in her family had died by age 50, and she's now 40. Well, she went to a cardiologist who specializes just in lipids and cholesterol outside of Chicago. Now there's a new injection coming out that you give once a month. Her cholesterol level on 3 medications was still 292. Now that she's taken this shot, it's 102. And these are, and she's doing all the right things about eating properly, high quality fish, watching the carbs, keeping the diet low fat. All right.